So I, uh, thank you. And so my name is Dr. Alicia Liberman. And as Peter kindly said, I am a practicing rheumatologist for adults and children in Buffalo, and I currently work at Roswell Comprehensive Cancer Center. And so I see a variety of things, but I'm excited that we now are open. We have a clinical trial that's open for CAR T cells for a number of autoimmune conditions, including myositis. Um, and and I know this group is wonderful and includes a wide variety of the inflammatory myositis subtypes. And uh, CAR T cells are currently being investigated for a number of the different inflammatory myositis types, although they're not yet available for inclusion body myositis, although there are some potentially exciting things coming there. And since we're talking to a broad group, I also wanted to just to have a topic about talking about different ways, things that can support muscle and nerve health that we know a bit about. And then as a second part of the talk, I wanted to talk a bit more about CAR T cells, what's available in New York, Buffalo, and the New York City area, and then some details about the trial that's open in Buffalo. And then absolutely, this can be very informal, and I have lots of time too. So any questions you have about CAR T cells and what the different trials are like, I'm happy to answer. And I love histopathology, and I just think it's always a good reminder how beautiful the muscles and all the connective tissues are, even whether they're healthy, whether they're inflamed, we can still love them, and they are beautiful. And so things that I wanted to cover today briefly were um, there's a process called autophagy, which is something that our muscle and nerve cells, actually all of our cells, use to regulate their metabolism. And it's something that's dysregulated in all forms of myositis, potentially for different reasons. And there's some actionable strategies that are really lifestyle based that we can all remember to help support healthy autophagy. Just cover briefly some of the similarities and differences in the different types of myositis, which may play into different therapies, different therapeutic strategies. And then just to cover what is CAR T cell therapy and the current clinical trials that are around. Since I'm sharing my slide, actually I have a question. Is this blocking the picture? Do you see the picture? Like if I
No,
have
nothing's
the,
blocking it. Looks fine on my screen.
oh, all right, it's just on my screen. Excellent. So autophagy is a very funny word, and if you break it down, auto and phagy, in Greek it means self-eating, but really, which sounds a little odd, but really what it is the process cells use to recycle their proteins and the little teeny tiny organelles inside the cell. So it's our own natural recycling process. And it's the type of thing it's not necessarily good or bad. It's something that you want to have in balance, like all things in our body. You want a bit of both for some homeostasis. It's really important in recycling our cells' old proteins and old mitochondria. The cells are always going through the process of cleanup, and so this is basically autophagy is what promotes that cleanup, and it breaks down the proteins and the organelles back into their basic components, and then your cell could use them to build something new. And so keeping this process healthy and well balanced keeps your muscles healthy, and in particular the nerves. So our nerves are perhaps the most delicate tissue in our body. And so we want to keep them happy and healthy, and they have to be very resourceful because they often don't have a great blood supply. So this is how they recycle their proteins to stay healthy across the lifespan. And autophagy, I don't know if if this word has come up much just in just regular in your reading and others in basic or in what am I trying to say? In it comes up just in general health awareness, podcasts and readings all the time because it's so important, essentially for all the different organ systems in our body. Um, And so there is a ton of research that's going into ways that we can either promote autophagy and this is for muscle health, for nerve health, for longevity. So for our billionaires that are trying to live for a very long time, there's a lot of therapies that are going into promoting autophagy, and a lot of research that's going in towards inhibiting autophagy, where we would like cells to be a little less efficient and resourceful, such as cancer therapy, and some potentially autoimmune conditions, although it's a complicated process and we're still sorting that out. And so autophagy relates to it relates to metabolism in the cell. And there's this complex in our cells called an mTOR complex. And it's interesting that part of its name is actually part of the drug that binds to it and can inhibit it. So mTOR stands for mechanistic target of rapamycin, and rapamycin, interestingly, is a medication that is been used for a number of years and is currently in investigation for inclusion body myositis, and potentially may be useful for other forms of myositis and autoimmune conditions. This mTOR complex basically sits in the cells, and it's a sensor of what nutrients are around. So it's telling the cell, it's giving the cell important information about how much glucose is around, how much protein is around, how much fatty acids are around, and if those levels are low for a period of time, then it turns on. It turns on the recycling mechanism, and you starts to break down some of the older proteins or organelles. And so that's how it helps to regulate metabolism and homeostasis inside the cells. So when the complex is activated, recycling is off. I may have said that backwards before, I'm sorry. And when the complex is activated, recycling is turned off. When the complex is suppressed, that's when recycling is on. So it's one of those, sometimes keeping the on and the off straight is a little bit confusing. Um, and again, just getting back to, you don't want too much or too little. You really want just right, because too much autophagy, basically, either you could start breaking down things that you need in your cells to keep the cells alive, and you could, if you had way too much, such as if your muscles were really inflamed, for example, you could start to break down those muscle cells and lose muscle mass. And in other forms, you could have cells they have become so efficient and they're so good at using autophagy that they are living longer than we would like them to. We would like these cells to maybe go away because they're not functioning properly anymore. They're very inflammatory. And then also cancer cells are very resourceful, and we would like them to stop recycling and go away. And if we don't have enough autophagy, then we start to get um, basically messes inside of our cells. We get proteins that are misfolded or non-functional, and they can build up, and the cells are not breaking them down properly. You could get mitochondria that are old and not efficient or functioning properly. And so then the whole metabolism inside the cell isn't able to regulate itself properly. And in inclusion body myositis, so this became something that everyone started thinking about because of the inclusion body itself. What it is a small misfolded protein that has been detected when on muscle biopsies, the pathologist can actually see it. And so that gets people thinking about, so why are these proteins building up? Is there a problem in the pathway breaking down the protein? And so that's how the relationship between autophagy and thinking about mTOR inhibitors for inclusion body myositis specifically, how that came about. And natural ways that we regulate autophagy are things that probably we all strive to do and we all find difficult to do. But muscle contraction, so just simple contractions, whether it's formal exercise or sometimes there's physical therapy techniques to get the muscles to contract, that process by itself stimulates a protein called AMPK, and AMPK blocks the mTOR complex, And so that turns on autophagy. So exercise promotes autophagy. Free fatty acids. So free fatty acids get in our bloodstream from um, actually often from very sweet things like desserts. So sweets actually raise our free fatty acids. And that's an interesting balance where free fatty acids, if they're a little bit high, they turn on autophagy. So fats are not necessarily a bad thing, but when they are really high, like maybe there is a metabolic issue, and your doctor may have mentioned they're so high that it's time to think about some therapeutic strategies to bring those down. They can get so high that they actually block the process of autophagy directly, where and so then the proteins can't break down. So there's it's a bit of a balance there. And then this is probably not a surprise, but when glucose is high or insulin signaling is high, those both turn off autophagy. So the this is basically, it's all a sensor about nutrient load. So if there's plenty of glucose, and whether it's by itself or glucose bound to insulin, there's insulin signaling, those turn off autophagy. So certainly diet and exercise play a direct role here. And so I think it's just a good, these are all lifestyle things that I think most of us work to include in our routine, but there is actually a direct cellular reason why these things are helpful for our muscle cells, for our nerve cells, for them to help clean up the old proteins and stay healthy. So physical exercise and all forms of physical exercise have been shown to promote autophagy, whether it is resistance, so a little light weightlifting, does not need to be heavy weightlifting. And in fact, with myositis, you really should not be doing any intense weightlifting, but light weightlifting with reps, aerobic exercise, or kind of low impact endurance type exercise, stretching based exercises, those will all help. Anything that's activating the muscles will help promote autophagy and help them stay well regulated. And so you'll see goals that are really in line with the American Heart Association. Aerobic exercise, if we can get about 150 minutes a week, which is either 20 minutes every day or 30 minutes 5 times a week, in a couple sessions of some resistance exercise, which you may be able to work in throughout the day. Those can be really helpful. Nutrition too. So because the nutrient levels turn on and off autophagy in our muscles and nerves. If there's some interesting, thoughts around intermittent fasting and what to eat or not to eat after exercise. And I think sometimes people get really into the nitty-gritty with it, but in general, it's trying to focus on low refined sugars, low glycemic foods, so things that take a little bit to digest, making sure you're getting enough protein, enough fat, and everyone is in a very different scenario when it comes to their overall health, especially in a complex condition like myositis. So I definitely would not promote any sort of long-term fasting, but it may be something reasonable to talk about with your physician if intermittent fasting, where maybe you only eat for 12 hours out of the 24 hours, or 8 hours out of the 24 hours, if something like that would be reasonable or safe, then you have that period of time where you're turning on and you're turning off the autophagy to keep things in balance. Polyphenols are natural inflammatory substances that are found in lots of different parts of our diet, and they're very high in teas, green tea in particular, coffee, and then there's other seasonings and supplements like curcumin and resveratrol and berberine. Those have all been shown to directly stimulate that AMPK pathway. So those are easy things to potentially add in to your diet and as supplements or just as regular nutrition. And then sleep and circadian rhythm are also important. So when we're getting good restful sleep, all of the cleanup pathways in our body are activated, not only in the cells, but also in the lymphatics and in our brain. So whatever we can do to get enough sleep and good restful sleep will really help. And that includes, if there's any question of sleep apnea, looking into CPAP support and those sorts of things, so you're oxygenating well overnight. And then circadian rhythm too. So actually there are some studies that even so low doses of melatonin may help promote autophagy. So there's a lot of research coming on this, and I think it's largely being driven by the longevity movement and interest, but it's only the more they learn about it, it's only going to benefit the rest of us. And in particular, if you have some muscle tissue and nerve tissue that's extra vulnerable, all these things just become extra important to try and maintain function and help them regulate. And this was a nice overview from Nature Drug Discoveries. It's from 2017, so it's a few years old, but it's still very relevant. And this is about different medications that can promote autophagy. They're on the top in the blue, and on the bottom in the reddish orange. Those are all inhibitors. For the most part, they're all still they're not medicines that are used commonly and that you would be exposed to. They're really being looked at more for cancer therapy. But if you look on the top, the activators, we have physical exercise. We have metformin, which some people use and is really good at bringing down free glucose levels and improving tissue sensitivity to insulin. So that's a common one. Also, in the next category, we have the mTOR inhibitors like rapamycin and everolimus, which are now being studied in inclusion body myositis and other autoimmune conditions. And resveratrol is in there that supplement. So this list is going to be growing and growing over time. And this is the current clinical trial of sirolimus. So sirolimus, again, is that mTOR inhibitor that's been around for many years. It's actually very commonly used for inflammatory conditions, either to treat or prevent. So for folks after they've had a bone marrow transplant, or if you've had an organ transplant like a kidney or a liver or heart, sirolimus is actually commonly used. So it's not a new drug. It's a repurposed and maybe a better appreciated drug in that it has this dual role. So it does calm down the immune system, and it calms down activated T cells, and it also increases the level of what are called Treg cells, which are a much more calming, like mediator type of T cell. And then it also promotes autophagy. So it is a potentially promising therapy for inclusion body myositis. There was a phase 2 that was published, and it had some promising trends, although the overall result was inconclusive. But it did lead to this phase 3. And I just checked on the clinicaltrials.gov site today, and it looks like they've met their enrollment already. So that means there should be some good data coming out in the next year or two. And it is a hefty dose. So now that I work in a cancer center, actually I treat a number of people with GVHD with sirolimus. 2 grams a day, or should be 2 milligrams a day. That's a typo. That is a hefty dose, and so actually I'm curious to see how people will do with this. But I think the story about sirolimus is probably going to evolve over time and figuring out the right dose. It's a drug that you could optimize with the right level. And these clinical trials are often looking at improved strength and, of course, improved function, which is the number one strategy. But then also in inclusion body myositis and other forms of myositis, it's also important to look at maintenance and making sure that people are not. Could this have a role in preventing further muscle loss or further nerve damage? So glad that this is progressing, the rapamycin study. And there's probably more to come when it comes to autophagy inhibitors. It's interesting that it's used in the organ rejection and bone marrow transplant world, but it's not been looked at for other forms of myositis right now, because I think because it's very T cell directed, it would have a lot of potential for polymyositis and potentially antisynthetase syndrome. So it's yeah, I think this will be a promising therapy going forward. And like I said, I think the 2 milligram dose is rather high, and but it's a very reasonable thing to, even though it's still in clinical trial. I do know some neurologists and rheumatologists who have prescribed perhaps lower doses off label, and I think it's a reasonable thing to have a conversation about with your specialist. Um, and so then I wanted to switch toward just switch gears and talk a little bit more about the different types of inflammation that we see. So all of these all the types of inflammatory myositis, they're very inflammatory, of course, is their name, but there's slightly different flavors in the mix of the cells that are causing the inflammation. So in dermatomyositis, and actually that's on the upper and lower on the left, you have a lot more inflammation coming from CD4 T cells and macrophages. And then in antisynthetase syndrome, which is kind of a variant of dermatomyositis, you have more CD8 T cells, and you also have a lot of antibody-driven inflammation with the dermatomyositis and the antisynthetase syndrome. Certainly in the immune-mediated necrotizing myositis, a lot of antibody and complement-driven inflammation. And then in polymyositis and inclusion myositis, inclusion body myositis, it's much more CD8 T cell driven. And then you can also get some neutrophilic inflammation too in inclusion body. And CD8, so T cells are they are very tough and very stubborn, and they don't tend to respond to steroids very well. So we can give very high dose steroids and they just won't go away. And that's in part why these conditions are so treatment refractory. And they're in the tissues, deep in the tissues, which can be hard for antibodies to get to. And so that's why I think you see different mixes of therapies being more or less successful in different conditions. In the inclusion body myositis, they have this very specific T cell that has a marker, the KLRG1 T cells, which usually you don't see in other places. And so there is a clinical trial of an antibody that targets that particular T cell that's ongoing right now, which is encouraging and exciting. And the CAR T cells that I'm going to talk about next. So the CAR T cells go after B cells. We don't have any CAR T cells that will attack another T cell. But there is a whole new branch of this cell therapy called NK, CAR NK cells. And those could go after a T cell potentially. So, we're several years out from that, but there's still a lot of potential on the horizon. This can be available to all the different therapies. And inclusion body myositis has the extra challenge of damage to the nerve. So right where the nerve comes and talks to the muscle, the neuromuscular junction, there's damage to that nerve. And that's something that we don't see in other forms of myositis until much later. And so any sort of neurotoxic medication, such as high-dose chemotherapy that's given with the CAR Ts, it's much higher risk to make inclusion body myositis worse, in fact. So that's just an extra consideration there. And this is another busy cartoon of all the different types. This is just inflammation, different types of inflammation that we see in myositis, which we don't have to go to in too much detail, but I wanted to just comment on. So the autophagy is that we talked about before it regulates our cellular metabolism, and it's influenced by the nutrient environment around the cells and activity in the muscle cells. It's also affected by inflammation. So if you have a lot of inflammation signaling, so the tissue is really inflamed, in particular this trail directed signaling will promote autophagy, but in this form, when it's being driven by very high levels of inflammation, it can be the harmful form of autophagy where the cells are actually eating up their own the nutrition that they need inside, and it's the form where you're leading to cell death. So it's that balance where you want to promote healthy autophagy, but the inflammation-driven autophagy can lead to muscle cell death prematurely. So that was just a brief overview of autophagy in nerve and muscle cells and the potential of rapamycin. But I do want to switch gears and talk about CAR T cell therapy in active and immune-mediated myositis, because there's a number of open clinical trials in New York right now. Right now, these are open for dermatomyositis, polymyositis, antisynthetase syndrome, and the immune-mediated necrotizing myositis. And they all have some similarities and differences. We have the one trial that's open in Buffalo right now, and then all the other trials for myositis are in the New York City area. And they're all a similar design in that some chemotherapy is given first. So that's given over a few days. And then you get an infusion of these modified T cells that are essentially, they're modified to recognize and go and attack B cells, which are the cells in our body that make antibodies. And so with a combination of high-dose chemotherapy and these very directed CAR T cells that can get into the tissue and get into the lymph nodes better, it's the theory is that this can provide essentially an immune reset. And so a deep reset into the tissues and to allow people not only to get the hope is that you can get your autoimmune condition under much better control, but to be able to have some long-term control, potentially even off therapies. And these are still very early days, and the trials are all phase 1, which means there's still several steps before they become an accepted therapy. We have to figure out first if they're safe, or are there certain things we need to be mindful of, or make sure we're not exposing people to, and then looking at how effective they are and how long that effect lasts. So it's been getting a lot of news the past year or so. A lot of the trials were first in Germany, and there's a number in China, and then they're finally opening up in the US over the past year. So some very promising early results. And this is just a kind of a nice picture of this was a myositis patient in China, and it's a very similar CAR T therapy to what's available in the US. There's just a very subtle difference, but there's no reason to think it would be any different as far as efficacy. But it's a nice picture showing muscle inflammation, lung and skin inflammation before. And this is somebody who had a necrotizing type of myositis, which is remarkable in that they're very treatment refractory and hard to get regeneration and with our traditional therapies. And then the follow-up 6 months later, and this is somebody who's off therapy, not on steroids, not on immune suppressants. This is after the CAR T. Their MRI shows that the inflammation is gone. The muscle is looking very healthy. The lung inflammation is better. The skin inflammation is better. So that's what we are really hoping that these therapies can provide for you with myositis. And again, this is phase 1. We don't know. We're still learning, but there have been some individuals with good results. And so the current trials that we have in New York, there's in Buffalo, this is the trial that I'm involved with, and this is for the company called Adiset. It's a phase 1, and it's a little bit different from the others. So this CAR T trial uses modified T cells from healthy donors. So they already have screened donors. They've already collected the T cells. They modify them. They store them. So then they're ready to be shipped whenever we ask for them. And the other trials, and these are we're the only site in the U.S. There's other sites around the globe, but we're the only site right now that's doing this allogeneic CD20 CAR T trial. The other trials that are in New York City, these have many more sites throughout the country, and it's been open. These have been both open much longer. So at NYU, at Mount Sinai, and Columbia, these are all sites for the Break Free trial with Bristol Myers Squibb. It's also a phase 1. They're all phase 1s. These are autologous, meaning they collect your own T cells, modify them, and then it takes about 2 to 3 weeks, and then they ship them back, and that's when you're treated. And it's a very similar process with the other trial. This is with Cabaletta. It's called Reset Myositis, and that's at HSS, Memorial Sloan Kettering, and Children's at Montefiore. And so this is a nice trial in that it's open to pediatrics too. And so I'm hoping that we see more of that. And I wasn't sure. To be honest, my patients with myositis, I learned the most from. I think you guys, this is such a challenging disease. It's true. You often do know more than the physician. Um, and but I don't know if this would be. I assume you don't need this, but I was just going to show. I wanted to get. I don't know how to go to this box. I just wanted to. Well, never mind. I was going to pull up if anyone has not used the clinicaltrials.gov website just to show you how to find these and then how to find the contacts. If anyone has questions about that, I'm happy to show you that. Because it's not the most straightforward website. And sometimes it might be a little bit unclear about who to contact or how to contact them. I think I already covered this. So autologous means it's your own T cells collected, manufactured. They're basically they're modified to express a marker so that they go after a very specific B cell. So they're not going to come back in and attack your other tissues. They're just going after the B cells, trying to kind of clear those out. And then if it's allogenic, they're from healthy donors. And then these are, so I am able to share more details about the Adicet trial since I'm involved. And the other trials, they're all still phase 1 and the companies they kind of hold some of the details close to their chest. But the Adicet trial, these are the T cells that are collected from other donors and they're modified. And they use a very specific type of T cell. It's a gamma delta T cell. And the reason for that is that these T cells are really good at getting into tissues. They get into lymph nodes really well, spleen, and the muscle tissue, lung tissue. So that is a unique characteristic about these. So that's really part of oh, that's a blank one. It's too blank. No, because I'm creating them. That's why.
Those are
So
my favorite slides.
Yeah. That's something a little bit different about them. All of the other CAR T cells are they're CD19s and they're alpha betas. And they were developed first for treatment of lymphomas and leukemias. And so there may be some difference there in kind of what we're looking to target in autoimmune conditions versus the blood cancers. And this was a nice slide too showing. So I don't know if anyone here has ever been treated with an antibody called rituximab, or its shorthand is RTX. It's a medicine that's been around a long time. We use it for different autoimmune conditions, and it blocks it binds to B cells that have a CD20 marker on it. But interestingly, it also depletes these other B cells with a CD19 marker on it. And Rituxan and CAR T cells will bring those levels down in the blood if we drew blood and checked and say, yep, we don't see them anymore. But we also know Rituxan doesn't work as well as we had hoped for most autoimmune conditions, and they will come back usually after 6-9 months. And it doesn't seem to do a good job of getting into the tissues to eliminate those B cells. So this was a comparison where somebody had to have lymph node biopsies before and after. And this is showing that after the CAR T treatments, actually it gets in there and it really wipes out both the CD19 and the B cells in the lymph nodes, whereas they were still detectable sometimes at high levels just from Rituxan. So that's something a little bit different so rituximab just being an antibody versus the actual modified CAR T cells being able to get in there. And I keep doing it. I just keep hitting enter. My goodness. This is also a busy slide, but we can go through it, or I can answer any questions if people have about the eligibility for the CAR T trial. So because they're essentially all the same right now for all the different myositis studies. The FDA regulates these things very, very closely, and so there are a lot of requirements And over time, that is going to change because so far the therapies have been quite safe and effective. But with a phase 1, they're always very strict. So when it comes, so it's a number of different myositis subtypes, but there is a classification criteria that was published a few years back, and so um, you'd have to show that you either definitely have myositis or you probably have it, and that's a combination of lab studies, and whether or not you've had an MRI or an EMG or a muscle biopsy that helps support the diagnosis. And the condition, your muscle inflammation or myositis spectrum still has to be active despite having tried a few other treatments. So either still some muscle weakness, and then there's some other assessments that look at how the myositis is affecting your function. Um, it does allow for active disease to be found a number of different ways. So high muscle enzyme levels, abnormal biopsy, MRI, or EMG within the last 3 to 4 months. And they do check again during the formal screening. Or if you have dermatomyositis, then active dermatomyositis rash or active interstitial lung disease. At least one detectable myositis antibody, and then having had tried at least 2 immune suppressants besides steroids. So azathioprine, methotrexate, leflunomide, Cellcept or mycophenolate, IVIG, tacrolimus, cyclosporin, Cytoxan, Rituxan, or a JAK inhibitor. So 2 drugs for at least 3 months, and you could be on them at the same time, but but those are the general requirements. And then the logistics, what does it actually look like to participate in a CAR T trial? So first, it's the first step is really talking with your rheumatologist or your neurologist, whoever's treating you, and thinking through whether this would be a good option for you, and they can kind of help look through the inclusion criteria too, and see if, yep, it looks like you may be a good candidate for it, and it has to be something that, of course, that you're interested and comfortable doing, and then you reach out to the trial. And they'll usually ask for some records to take a look and then bring you in for formal screening. And then the screening period takes it's 1 month, and there's some testing, and they want to make sure that, yep, you meet all those eligibility criteria, all your questions are answered. There's no other risk factors that we find that would make the chemotherapy. It's really the chemotherapy that people are concerned about that could potentially have a safety issue. And then if everything looks good, then you can be enrolled. And the first part of the treatment process is the chemotherapy. And it's a medicine called Cytoxan and then another one called fludarabine. And you come into an infusion center, and you get an infusion, then you go home and you do that 3 days in a row. And then on the fourth day, you come in and you're admitted to the hospital, and you stay in the hospital for at least a week. Generally, it's just a week. It's possible you would be in there a little bit longer. But that's when you actually get the infusion of the special CAR T cells, and then you're monitored very closely to see, how do you tolerate them? Are you having any inflammation from them? And after a few days after the chemotherapy is when we also start to see cell counts go low. And so that's the other really important reason why you're in the hospital, is so that you're monitored very closely by a team. And this is I think in all cases by a cancer center team or oncologists who are very used to giving the chemotherapy. And so you're on some special protective medicines. They're on some medicines that can help bring your cell counts back up if they're taking a little bit too long. And then after a week, as long as you're doing well and the cell counts are safe, then you can go home, and you're monitored very closely for 28 days. And then after that, the visits space out. But you are still monitored for about 2 years. So that's why the location is always can be a factor. It's just thinking about the logistics of being, what's the closest center? What would travel look like? All of the companies do provide some reimbursement for travel and housing. So it's always good to ask about that because, so that's not a barrier if it's something that you really want to do and you're eligible. There is definitely support available, I know, from all the different companies. And this is for the Buffalo trial, so it's the Adiset trial. And this is the identifier, or you can easily search it. And then contact. So my clinical research coordinator, her name's Laura Ryan, and she's the contact that's actually listed on the website. But really, this is my email as well. And I am happy to, if you wanted to reach out to me directly, that's absolutely okay with me too. And then, like I said, we really would, usually we just have a phone conversation. You can tell me a little bit about what's going on, either send records or have your physician send records, and then we go from there. And that's what I had for right now, but I know there's probably a lot of things I haven't covered, or any questions or things that you had just hearing about CAR T therapy in general, or about the other. I do know folks at the other trials and the trials in New York City, so I'm happy to tell you about those, what I know as well. And if I get my screen format down, we can always look up who you need to contact to get in touch with those, as if that would be helpful.
Thank you. Thank you, Dr. Lieberman. Greatly appreciate the talk and the information. It's fascinating. There's a bunch of stuff in there that certainly was new to me. I suspect to many of us. I, for example, was unaware of the nerve cell involvement in IBM, which is interesting.
Oh,
Uh,
it's my
so,
heart goes out. I have some very, very dear patients with inclusion body myositis, and it's such a puzzle and it's such a frustrating condition. And it's fascinating that T cell that I was talking about, that CD8 T cell, it sits right at where the nerve comes and talks to the muscle.
yeah,
It's just in the worst possible
perfect.
spot. I don't,
Yeah,
yes, I know.
great.
So it's but we're gonna get there. We're gonna figure some more things out for that.
And I saw a question in the chat asking about, can we show the clinicaltrials.gov website? If you can't, I can probably bring it up on mine and you can walk us through it and I can navigate. And Molly, thank you for putting in the chat there the link to the TMA website, which lists clinical trials as well. So that may be another place to go to find clinical trials. But if you can get it up on your screen, that's great. Otherwise, I can bring it up in the city.
There we go. You know,
That
there's this
looks
little
like
black
you're.
bar that's at the top that was just blocking me. So there we go.
Oh, yeah. We didn't see it.
Okay,
It's on your screen.
so
Yeah.
this is just so this is what would come up first. And let's say you, for condition, you just typed in myositis, and it could be any form. Sometimes the more specific, if you too specific, and then you don't get as many results back, like any search engine. And then for interventions, you could just put in CAR T. And then for location, well, yeah, it's for New York. And then these are the ones that come up. So this is what's the, I can never keep the therapy straight. This is the Bristol Myers Squibb. So these are CD19 autologous CAR T cells, and it's a trial for a number of different autoimmune conditions. And then it'll tell you a little bit about, so up here it'll say, so it's for lupus, it's for IIM, it's for scleroderma, and it's actually for rheumatoid arthritis. And then the location. So if we scroll down to New York, and then so some of them were either open or were in the process of opening, and then they just were not able, it just didn't happen for some reason. So if you just look at the green where it says they're open and recruiting, you've got NYU, you've got Mount Sinai, you've got Columbia. So three big centers right there in the city. And then for example, this one, oh, it doesn't open up. So this is Marguerite Weisendagger, who's a rheumatologist who works there. And there's no email, so it's just a direct phone number. So you would actually be calling her or maybe one of her coordinators directly. And yeah, I guess they're not saying kind of what everyone's different roles are. So some of them may just be the trial coordinators, some of them may be the physicians themselves, but they're absolutely, but don't hesitate. If it's something that you're interested in, just reach out. And I guess they're all phone numbers. So you just leave a message and someone will definitely get back to you. And then I wonder, sometimes these are in other sites. No, I would say sometimes the companies themselves will have, oh, yep, here we go. If you're having trouble getting a hold of anyone, and there could be any number of reasons for that, if you reach out to the company directly, either the phone or the email, they always have a big staff of people who are very helpful and will help you get in touch with whoever you're trying to get in touch with. So don't hesitate to reach out to the folks directly. And then if you're having any trouble or if it's been a couple days, just go to the sponsor itself and they will definitely get in touch with the right people.
Thank you. Yeah, that website is although kind of complicated, it's very useful. The TMA website is another place to go. So, um, uh, and with everyone, we tried as much as we can to get the word out as we hear about clinical trials so that people know.
Yeah, you just want to know that they're available and
Yeah,
generally what's involved and
yeah,
what conditions they're looking at. And there's a number on here, I think two or three that are open for inclusion body myositis as well. So there's ongoing research there too.
great. I only know of
And
two. I only know two therapeutic ones anyway, but
oh, that's too
I think
therapeutic. That's right, because the
both of them are,
sirolimus one is
I
just
think
closed
both of
now.
them
Yeah.
are closed at this point, but
Hmm.
I'm not 100% sure. I do take a look at that, obviously. There are a couple of questions about timeline in the chat. Kelly wonders kind of what the timeline might be for CAR T therapy actually being, approved, which is mainstream therapy, given that we're in phase 1 trials right now, assuming obviously that the results of the trials are gone. And Molly asks, how long is the phase 1 trial going to go?
Hmm. The phase one, so I can speak to the one I'm participating in, since it just opened for myositis and it's going to be open for at least the next 2 years. So there is a big window there. And then and even though it's open for that long, then even after the treatment, you're still monitored for another 2 years very closely. So they are still going to be open for a while. There are some of the phase one trials that uh, well, really, they've been open longer in other countries, but there are some of the phase ones that are coming to a close. The companies are just about to open phase twos. So I don't know if any of them are Novartis has a phase two that's open, and there's a number of other companies that are coming. So that's the next step. So I think if everything, unless anything, this is a crystal ball problem, we don't really know, but really the results and the safety have been very encouraging so far. So I think we'll probably get to an actual FDA approved therapy that would be outside of a trial in the next 3 to 4 years. I think that's realistic. So that's not too far off. And more of these trials along the way are going to be popping up. So then you're going to have you're going to there'll be more opportunities in different cities, and they will eventually be outpatient. So all the companies are pushed because they've been safe. Likely that hospital piece is going to get shorter and shorter, and it's going to be outpatient. Um, so that'll be another plus as far as the logistics of travel, and no one wants to be stuck in the hospital for a long time.
No one wants to be stuck in the hospital for a short time, but
Or a
but
short time,
that's
really at all.
yeah,
Really you want to just avoid those
yeah,
places. Yeah.
yeah,
Yeah.
not a place that one enjoys going to. So, Jana, you have a question about overlap myositis conditions there, and wondering if those you can read those are CD4 T cell mediated and refractory to steroids. So I guess she's asking about those, what's known about that. Janet, why don't you unmute and if I didn't get that right, please jump in.
Yes, and for example, anti-PM SCL 100,
SCL. Hmm.
yeah, which is what I have.
Well, it is, I think that is still under the category of myositis associated antibodies. So it is every one of these clinical trials. So the sponsor company has a rheumatologist we're on the ground. I would collect records and do an exam But there's always a rheumatologist who's kind of the monitor for the trial that is the final decision maker. And so it may depend on, it may, in something, in a condition like that where it can vary quite a bit. How much inflammation looks like myositis, how much looks like scleroderma. And if we could say, okay, it's primarily this condition or it's primarily that condition. So I think if you were, it might require somebody putting their chip down and saying, okay, you're mostly in this category or you're mostly in that category. Now, if you're a true overlap, that could be very challenging, and the clinical trials may be hard to enroll in because they're going to say, well, you don't really fit in our neat little boxes that we set up with the FDA. And so, I guess I wouldn't know without, with all the details, but I still think it's entirely possible. So even if everyone has told you, look, that you have an overlap condition, you have features of that and this, well, so anti-synthetase syndrome is just like that as well. You have a number of features of, different, it doesn't look like dermatomyositis, doesn't look like polymyositis. So if it's something, if you think your condition is not well controlled and you've tried a couple therapies, I think it's still worth considering. But often the trials will say, well, we would prefer, we're not really, we don't want you to have a whole bunch of different autoimmune conditions that are uncontrolled. And then they just don't have a good way of monitoring safety and, well, efficacy is really what they're looking at. So, but further down the line, definitely things will be available. And outside of CAR Ts, every year there's at least one or two new therapies for the inflammatory myositis spectrum or the scleroderma spectrum. So there's still more things coming.
Yeah, and I'm responding well to IVIG, so I wouldn't be a candidate.
That's true.
Reset myositis told me, despite having failed two immunosuppressant therapies.
Really? Oh, that's
Because the
interesting.
IVIG is working, I'm not acceptable to it. So that's
It
interesting
is.
for down
Yeah,
the
and
line.
it's a challenge. When it comes to clinical trials, right? If you find something that's working, but it may be cumbersome or require therapy, you have to have infusions a certain number of times, and right. So then you're looking at, well, which I'm not recommending, and I just think it's a terrible pickle to be in where well, I have something, but I don't want to be on it forever. If you stop it, then your disease will become active again. So then the clinical trial people might say something different. But when it comes to a condition like myositis or scleroderma, you never want it to be active because the damage can be irreversible.
Because there's at least two of us here. Marilyn, I think, also has the same autoantibody.
Oh, interesting. And that is very rare. Well,
Right.
there's
You think.
this whole support group. You guys are all very rare. So, but I think it's just extra wonderful that you have this so that you actually can find people who are in a similar situation.
But I didn't know
Um,
before I found out from the TMA meeting the previous year that it should be sent to Oklahoma Medical Research Foundation. I think and even that it was difficult to get my blood sent there, even after Dr.
oh, to actually
Dr.
get the
Vetter
correct
specified
antibody
it, but
test.
even then the hospital tried to send it, really wanted to send it
Oh.
somewhere else to LabQuest or
Yeah, whichever commercial lab they have a contract with. But
yeah.
no, it's true. Some research labs have much better, much more reliable testing. But trying to figure out how to get your blood sample there is not always straightforward.
Yeah.
Yeah. Um, oh, well,
No, that's
that is
helpful.
frustrating.
Yeah,
Yeah.
that's just something to pay attention to.
Yeah. And again, yeah, if the clinical trials being very strict, as you get to the phase 2 and the phase 3s, the requirements will change and will probably become a little more inclusive. And then once it's FDA approved, then issues like that won't matter so much. So
Right. Thank you. It's very
you're
helpful.
Oh,
welcome. That's
I
a good
know
question.
we're right at the end of our usual time here.
Oh,
So I'm going to go ahead and stop the recording again. Thank you so much, Dr. Lieberman, for for joining us and for sharing the information. Really appreciate it. Really glad to know that there are clinical trials out there, and particularly, some that are not just in New York City. Not to minimize the fact that it's important they're in New York City too, but it's nice to have them a little bit closer to some of us here. So that's tremendously good news. So thank you very much.
Thank you for the invite. I'm really honored, and I'm happy to come back and talk about other